Hello all, thanks for joining me. Today we are talking about Title IV-E Prevention Services Training Awards. This webinar was originally scheduled to happen live on April 7th, 2023. However, life happens, and here it is as a pre-recorded segment. After this recording is released, we will look to see if a live Q&A is of interest or if an FAQ sheet is the best way to go after this. If you are wondering whether this presentation is for you, I can go ahead and answer that it is. Whether you are a practitioner, a therapist working, this is information for you to bring to your employer or other people in your setting to come together and apply for one of these grants for training for yourself and for your colleagues. If you are a provider, this is really for you because you are the ones that will be applying for these awards and being granted them. If you are a person who works like a family services specialist within the local DSS, Department of Social Services, this is for you so you know what is available and reimbursable under Title IV-E. Same for CSA coordinators. These are high quality evidence-based programs that we'll talk about that will impact your entire community. So if you live in Virginia and you work in this space, this presentation has been written for you. So let's get started. Who am I and what am I doing here speaking to you all? My name is Rafaela Sale. I am the Associate Director for something called the Center for Evidence-Based Partnerships. We are a technical assistance center currently holding contracts for Virginia Department of Social Services and also DBHDS, as you can see there. Specifically for DSS, we are here to help with the rollout of Family First. We are a small team, a very small team of mighty researchers, and we have a certain set of values in that we commit to challenging ourselves and our partners in this work. And transparency. We practice secure and transparent data sharing. Our mission, we believe that all people have a right to resources that promote well-being, including high-quality behavioral health services within our own communities. And to achieve this vision, we engage and promote relationships as a key mechanism for large-scale change. So more about our approach. The center was contracted to complete certain tasks or certain asks, such as expanding services to Title IV-E, to help train the workforce or different workforces actually, to develop a directory where all practitioners who have been trained in high quality services live so they can be so that directory one day can be accessed by folks across the entire state to find these services. We also have been contracted to do the fidelity monitoring of evidence-based programs in Virginia. However, we are scientists, not just implementation scientists, but also psychologists. And we know that initial plans, especially large-scale ones, will always hit barriers. That's inevitable. That best laid plans always require revision, no matter what. And that any initiative where any change whatsoever is expected, which is everything we do, must involve a willingness to adapt and a responsiveness to what we learn as we go. In the background, we have a simultaneous process going on to assess fit of certain areas, fit not just of the environment, but of pre-existing service arrays. We pay attention to fit a program to place based on historical context of certain areas. We also have a stepped and multi-phasic engagement process for building partnerships in certain areas at the state and local level. And we monitor certain pain points in trainings and work with EBP purveyors to adapt their trainings for Virginia. So fit, infusion, and readiness are these sort of lofty abstract terms often that people can use, but they really do mean real process work with the folks that we're working with, in order to ensure that things actually stick around. That is our number one goal, that we are committed to sustainment, not perfection. And we want something to stick over time and make small adjustments driven by data that improve the level of services that families receive. And so while we're working on these deliverables, again, there are studies happening in the background that investigate things that we find along the way. We write these up and we release a report every year called the NAGA report. It's a needs assessment gaps analysis report. We just released the second one this month, actually. And we talk about certain things that really need to be mitigated or attended to in order for us to see any of the outcomes or to see sustainment of any of these evidence-based programs. It would be much easier, of course, to do one side, to just do the contract deliverables or to find problems only. But we know nothing happens in a vacuum, and that changes to one system will impact another. And we must work across systems and pay attention to what has come before us to expect the outcomes that we do. And so this model over here is just something that underlies all of the work that the center does, and recognizing that we are all interconnected and interdependent on each other's success. Okay, and this was our original agenda. We're not doing this anymore. This is a loose agenda. I have no idea how long it will take me to get through these things, but hopefully after this is done, one of our grad students will be able to sort of give you some time markers to see where you can skip around. All right. What have we done? I just told you who we were, so we're already done. Look at us making progress. Now we're going to talk about purpose of these awards. We're going to talk about evidence-based programs in general, Family First Virginia, the EBPs specific to that, how to apply for one of these awards, and then talk a little bit about what last year was like. Before jumping in, though, it's really important that I take a second to talk about language, because lots of different folks in this space, we use words differently. It doesn't mean that someone's using them wrong or right. And what I'm about to say doesn't mean this is the right way to use certain words. It's just the way that I'll be using them. Parent being either a caregiver, parent usually means like a biological background, but I mean caregiver here. I use those terms interchangeably, actually. Child, when I use the word child, I also include adolescents because they're our children. And then supervision versus consultation. These are two words that I probably would say are used differently the most variability. Supervision refers to internal or within agency regulatory process. So on-site supervisors who are in charge of making sure that patients are safe and that trainees are doing what they need to do in order to protect public safety. Consultation is different. Consultation comes from the outside. It refers to a training element that looks like supervision, but it's from someone that has a very specific set of skills, isolated to a certain thing that someone is trying to learn. And they're usually, and in this context, it's related to an employee of an EBP purveyor, the program developer. So when talking about children and families today, I will emphasize or refer to reasons for referral or presenting problems in terms of observable markers of distress that indicate whether a family is a good fit or not for an EBP. I'm making this decision because terms like, or phrases like family functioning or behavioral and emotional functioning are incredibly broad and a little bit too vague for what we're doing today. And diagnoses can be too narrow and really based on the eye of the beholder, or whoever is doing the assessment, unfortunately. However, I will name the ones throughout some diagnoses because I know these are important for billing, claiming, those kind of reasons. Providers, I use this word to talk about companies or agencies that deliver mental health, behavioral health services, not individual direct service providers. I use the word practitioners for that. Practitioners are therapists, they're clinicians, or the people actually in the room with the family. These can be bachelor level or master's level. They can be licensed or unlicensed. These are mental health professionals. Purveyors are the program developers, the trainers, the vetted spokespeople who represent a commercialized evidence-based program. They have a very clear stake in how this program is rolled out, and they care very much that it's done exactly the way that it was designed. And then training. When I use the word training, I am referring to the entire spectrum of training, okay, meaning workshops where someone is like literally just telling you information for you to absorb. It's not really bidirectional. I'm talking about consultation meetings that look like supervision meetings, consultation sessions and hours. I'm talking about live observations, proof of competence, like ways to prove that you know what you're doing and that you're doing the practice to fidelity. Training is anything to get someone to a level of fidelity and to maintain it there. All right, so I know that took a minute, but it's important. All right, so evidence-based, what is this like, all this hoopla and excitement about it? So what does it even mean? Why do we care? When you go to the doctor and you ask for, when you go to the doctor, do you have to ask for evidence-based medicine or just regular medicine? You don't ask. You just kind of get what is evidence-based because that is standard of care. And that's where we are in medicine. One day, we hope that all behavioral health care will be like this, that you don't have to say something is evidence-based or not to convey that this is something that should be used. But that's not where we are. Majority, unfortunately, of therapy, of therapeutic services out available in communities is not evidence-based. So I'll say that again. The great majority of therapy out available for consumer use and access or availability is not evidence-based. So that just means that they don't have studies out there. There are therapies out there that do not have studies that say they work, which can be really surprising to some folks. So just to break this down, words like cognitive behavioral, behaviorism, information processing theory, another one can just be cognitive theory, family systems theory, all of these are theories. These are the why. Cognitive behavioral says, our thoughts are related to our behaviors, which are related to our feelings, they're interdependent on each other. Behaviorism says, consequences and rewards dictate guide and shape our behavior over time. And then information processing theory is a different thing. And these are explaining the why. Then you have these treatments, which are the how. They're the sort of technical skills of that's related to the theory of how to treat certain issues and problems. So different protocols like coping couch is for anxiety for children. It's an old one. MATCH, which is a modular approach to therapy for children with anxiety, depression, and trauma or conduct problems, is part of the cognitive behavioral family. Dialectical behavioral therapy is a type of behavioral therapy. Parent-child interaction therapy hangs the same, applied behavior analysis. So treatments that share a why belong to a treatment family. Many of them have the same or similar strategies involved, really, and the same ingredients, but they're in different sequences, different formats, and tested just like how they were designed in their little package in big, expensive scientific trials or studies. So because they were tested that way, the idea is that they should be delivered on the ground the exact same way as they were tested. If not, then you can't really expect the same results that were seen in the trials. And that's why fidelity is such a big deal. Is it actually the way that it was supposed to be? Evidence-based really just means, and hopefully all of this is to say, or a long roundabout way to say, evidence-based is, we use that term to talk about things that have several controlled studies that prove families get better faster and for longer than if they receive that evidence-based therapy compared to what is normally out there for them in the community. So treatment as usual. And then there's also this phrase evidence-based services that is out there, and that's also very valid and an accurate term. Evidence-based services, though, talk about the entire system working together, the referral system, the folks that are noticing the need, and the actual providers and the practitioners delivering the actual evidence-based program, all of those systems working together to ensure the program is delivered as it was intended. So it's sort of like the solar system of it all. All right. So people ask, like, what's the secret to these EBPs? What are they so great? What's the magic? What are they doing that makes the families get better, faster, and for longer? There isn't really a secret. Sorry. And I know that probably our purveyors wouldn't really like me saying this, but I'm just going to be honest. A lot of these programs share similar practice elements, some of the exact same, like I said earlier. But what these programs offer that is so different from everything else is the expert consultation and extreme oversight that these companies that have a stake in these programs sort of require for someone to be trained and to continue. A lot of these programs, the purveyors, the people from the outside, they never leave. They just slowly reduce how much oversight they provide, but they never leave. And then there is also outcome monitoring. And this is a huge component of every single one of these programs. What this means is that consultants and practitioners are getting immediate data, as in like right after they see someone, on whether what they are doing is working or not. And they're using standardized measures to determine this. And standardized measures are different from just like us asking how people are, how you doing, rate from 1 to 10. They're different from that because they are designed to respond to reduction in symptoms, real reduction in symptoms, versus just up and down mood or like random hiccups in a family's life. So when we see a reduction over time, we can be pretty confident that something is working for them. So therapists improve with how they are using their skills. They are getting good at using what is needed in the moment to keep families on track. And that means their competence is improving. They're starting to develop this sixth sense, this art of clinical work. And, you know, a lot of practitioners already have that before training, but this sort of hones them to a certain way of thinking about things and delivering these skills. And they have like a cheerleader on their side, kind of watching them and making sure that when they're doing it right, that's noticed. And when all this is happening, it just so happens families get better too. So EBPs have absolutely program evaluation and quality assurance mechanisms built into them. Okay, that was fast. All right, so trauma-informed. It's important to bring this up because Family First requires that these programs that we're talking about are trauma-informed. That's all over within the language of the Act. So trauma-informed, and this is from SAMHSA, it means that we realize the widespread impact of trauma, that trauma begets trauma. There is a cycle where people are taught to accept trauma as normal, and in some cases, what normal and what caring relationships look like because of their experience of being in an unsafe and insecure place for quite some time in childhood. But it can also happen in adulthood too. Being trauma-informed means that we recognize the signs of trauma when we see them. And trauma responses can seem really odd at first, and especially to folks who don't know someone's history or how trauma looks, obviously. It can look like not caring about oneself at all. It can look like self-sabotage. It can look like disconnection or disengagement or not wanting help. Because trauma teaches people they can only rely on themselves often, and that others are more often unsafe and untrustworthy. So being trauma-informed also means we integrate knowledge about trauma into our policies and our procedures, and we change them. We think about how certain words, for example, can convey blame and shame to people in your care, which we know now throughout multiple years and decades of research that shame and guilt perpetuates trauma, and how it can be passed down throughout families and through genetic makeup and the way that genes are expressed with chronic trauma and chronic stress. And then the most important one, I think, for being trauma-informed is actively avoiding re-traumatization, which requires acknowledging where in the system this is happening already right now. And you don't have to look far because it is happening everywhere. But at the end of the day, trauma-informed is in essence how we see and approach people, and all of the EBPs that we'll talk about today lend themselves to being trauma-informed. All right, so what are these amazing programs that we are selling to you all, pretty much? We have, these are the EBPs that are in Virginia's plan for Family First, and all of these EBPs have shown to reduce out-of-home placement and entry of kids into foster care, which is the very purpose of the new Title IV-E funding stream, keeping kids together with their biological parent or stable home situation, caregiver, or family system when an alternative living arrangement with kin. However, providers, if you're listening and you're doing these therapies, you are not bound to only accept referrals from your local DSS. You can accept referrals that come from any system or place. So a training award is a grant that is paid directly to the purveyor from the center, from VCU, to train an awarded provider, you, or those part of your system, your community, to train the awarded provider and their employers, their practitioners. And some of these EBPs require training of staff as well, like administrative staff. Funding is available for these EBPs for training and then later for a reimbursement rate too. And providers on the ground are encouraged to set whatever rate they would like on that is competitive within their area. More on that later. So the first three, multisystemic therapy, functional family therapy, and parent-child interaction therapy, are not new to Virginia, and they were part of the original Family First Plan. I believe that was active in 2019. And then recently, 3 additional evidence-based programs that are all well supported were added. And there are very purposeful reasons why these 3 were chosen, which hopefully that will become really clear later on. There are also 2 types of awards that providers can apply for. And the first one is full, meaning they've never done any of this on any one of these programs before, and they want to do it for the very first time. And so that is a much, it's just a longer application process, or we ask for more. There are more steps. But there's also a type of award that's just called supplemental, meaning if you've started these therapies before, any one of them, and you need training for a replacement therapist on a team, or if you need, like your original therapist left and you need to train a new one, if you need something that allows you to have fidelity to the model, like materials, technical materials, technical support, like video cameras, Bluetooth for PCIT, that kind of stuff. Those are supplemental awards, and we're giving those out as well. And that literally is just like a few questions, because then we set up a meeting and talk to you after about it. So please know, if you're already doing these, there's money out there for you and there's support out there for you to continue to invest and maintain this EBP at your site. More information is at www.CEP-Va.org. Don't forget that dash, very important. All right. So if you want to know about any of the EBPs that I'm talking about today, you need more information, this is where you get it. So you could go to our website and our YouTube channel, which the actual experts, the people who know these programs, each one of them more than me, much more than me, they are experts in it, came last year to give a presentation on their program. We recorded them in an open house series, and those recordings are all available on our YouTube channel. They're not coming back because these programs don't change, right? When we talked about that in that way. You can also go, and this is the place that I would recommend the most after checking out the center's website, is the purveyor's websites, to contact them directly and ask them direct questions. They're out there for you and they are waiting to hear from you. Totally fine. You don't have to go through us first. You can talk to them first to see if you even want to make an application. You can also contact us too to ask about that as well. And we can provide support around that. And when we do that through an EBP funding meeting, even if you just want to these are short 30-minute meetings where you kind of just come in, you can ask anything about anything of these programs, how to get money, what these mean, what's a good fit for your site, should you even do this, based on the maybe your employee workforce, what you have available that could actually deliver treatments. Any questions, you can just schedule a meeting with us. Email us at ebplab@vcu.edu. We are dying to talk to you. I'm extroverted and we don't see a lot of people, so please, yeah, make an appointment. And we'll go from there. All right. So these are things we've done so far. Now I'm jumping specifically to Family First EBPs. And so the way that I'm going to go about these Family First EBPs is to introduce the program. What makes it different from others, I'm going to highlight those pieces. So let me finish what I'm saying, I'll come back, and what it will take to implement the program. So these presentations are really geared for those who are like ready to start doing something, to make an application, to put an application, and what providers and practitioners need to know what they're committing to, what they're about to get into, based on any specific EBP. And it's also important for referral brokers, those in the room that are making referrals to these services, to learn these different programs and perhaps begin to encourage the providers in your area to apply, again, for a training grant, and to begin to know these by name. And this is important for practitioners because, again, we want you to know what training what entails. Practitioners are probably the most important part of this system. I mean, every single part is, but getting their consent and their buy-in is also important. And then not the most important part. I would actually say the admin person that like is the first person who picks up the phone when families call for services. That's probably the most important person in any sort of system. But anyways, okay. This is wild, just talking out into this. Okay. Here's just like a really quick, easy overview visualization to show the age ranges for these family first EBPs and what they span. So you can, so they're also color coded too, according to theory and general orientation, to kind of show the similarities amongst some and the differences that some have compared to others. So for example, functional family therapy is a traditional family systems therapy. Multisystemic therapy is a systems therapy, systems orientation. Brief strategic family therapy is also a family therapist, a family systems therapy theory underlying. So the entire family would attend to any of these sessions, okay? And that means like one caregiver and one child, the identified patient at the minimum. So this is, they have commonalities that make them hang together. Parent-child interaction therapy is sort of something that stands on its own, and that it is an intensive behavioral therapy. And we'll talk a little bit more about this later and what that actually means. The parents, both of them, if possible, are still, or one, whichever, are encouraged and have to attend these sessions because really the focus is on changing the parent and their skills. And it's done in, again, I'll wait because I don't want to tell all the secrets yet. And then there's family checkup and Homebuilders, which really use more of a cognitive behavioral model. And multisystemic therapy does pull this in as well. But family checkup, it's heavily based and sort of rooted within cognitive behavioral techniques and strategies while making sure to attend to the systems in a child's life. And Homebuilders is similar in that they bring in these techniques, these pretty effective techniques from traditional cognitive behavioral therapies, but also it's done within the sort of vessel of a case management model. But you'll see that Homebuilders spans the largest age range, family checkup, then I would say does the second longest. Then you have brief strategic family therapy, that's pretty long. And then the other three, the ones that have been originally in Virginia before, they are more sort of tight to a certain range. All right, multisystemic therapy is for 12 to 17-year-old kiddos. And this is flexible too. Sometimes they go a little bit younger. And this is for teens and preteens who are severely acting out. So there is absolutely some distress happening within a system. We see a difficulty of the schools to retain these kids. They're not showing up. There's academic failure, happens pretty early on. And these kids are usually substance abusing teens. And their families often, there's a history of that as well. So pretty complex, high conflict. The diagnoses more traditionally associated with these behavior issues are ODD, oppositional defiant disorder, CD, conduct disorder, ADHD even, and bipolar disorder. That's what you typically see for these kids, but those are just diagnoses. Multisystemic therapy recognizes that children live in a social ecology, and that's what this circle is showing, of interconnected systems that impact kids' behavior in direct and indirect ways. Children are a product of their environment, is pretty much what multisystemic therapy is saying. The child also influences their environment, and as their environment influences them over time. Fun fact, Mean Girls was written off a book called Queen Bees and Wannabes, which basically says kids are their friends, and MST would absolutely agree, I would say. It's still appropriate to refer to MST if presenting. So it's really for these kids who are acting out these externalizing issues, but it's still appropriate to refer to MST if the child is also presenting with co-occurring depression, anxiety, and things like that in conjunction with these severely acting out behaviors. Depression and anxiety just can't be the primary reason for referral. It's not best for that. Totally fine if the child or parent has a moderate intellectual disability or on the autism spectrum. Totally fine if it's moderate or mild. Let's see. Something that's very important about this model is that providers should know that MST requires that the program is delivered as a 24/7, 27/4, that doesn't make any sense, 24/7 access to a crisis. So this is a crisis model is included within this program. Things that you absolutely have to make sure are in place is that the child must be living with a parent or caregiver. A youth living independently isn't in a family context, so this therapy wouldn't be best for them. All right, so for every EBP, you're going to see a training timeline or a diagram just like this. It's an overly simplified visual of how long and sort of the requirements of training that these individual purveyors require. And it's the training that takes to give providers an idea of what they're asking their employees to do. For MST in particular, individual practitioners become certified, or teams become certified, and the site is called licensed once you make it through this training. Before training can even begin, though, MST has a program development process, which can last about 4 to 6 months or shorter, depend on how engaged the site is or how ready they are to go. They conduct a site assessment, visiting them on site to see how things are going. And basically what this diagram tells us, dark blue are workshops, so these didactic sort of pieces, these presentations that people get to absorb knowledge. And then consultation is helping folks use these with real families. Practitioners go through this 5-day orientation training. So do people who work on the site, administrative folks. It's on-the-job training. Then they also have weekly on-site consultation, which looks like supervision again, and MST expert case review. So they look at the case notes to make sure that you're doing what you should be doing, to working towards competence. And again, there's development planning for all professionals within that provider site. There's an additional 2 days. That's why there's a little extra box right here for supervisors or for people who want to become a supervisor on an MST team. Extra 2 days of training. There's also booster trainings 4 times a year. There's a program review every 6 months, a program implementation review. That's a report of how well your site's doing. There's so much monitoring, so much support, implementation support, because these folks have been doing this for a really long time. They know what makes MST stick or not. So again, this is really just showing you they have a quality assurance, a quality improvement process built in, training and ongoing support, organizational support. And these QA processes are required to be ongoing at all times. I mean, you'll always be having MST involved in your site to maintain team licensure over time. Again, a lot of these things, there'll be less consultation over time, especially if you start to train up an on-site supervisor. They can be the ones doing all the consultation internally, actually supervision. But they're always going to have some sort of thread still connected, even as they let up over time. All right, so MST practitioners, I mentioned earlier, but MST is a team-based model. So and this is important, one therapist sees a family, and that family just sees one therapist. They think they have one therapist, but really what's happening behind the curtain, what's invisible, is that there's a whole team sort of working together to make sure that therapist is a perfect, or not perfect, nothing's perfect, but an efficient and effective conduit of MST. Working on a team has also been shown to ensure fidelity because it creates accountability within practitioners. And MST, they pride themselves on being principle-driven and not obsessed with like a manual. So every session isn't manualized like some other EBPs. They just have a set of principles that you must abide by. Average duration of treatment in MST has said to be about 4 months. However, better results have seen when treatment lasts until significant improvement, or that symptoms remit, so then they're terminated or discharged from therapy, and that can typically take about 6 months. This is an intense therapy. A max caseload at any time is 4 to 6, but really 5 cases is good. It's really important for providers and practitioners to know that their staff that has to be dedicated to just MST. They can't really be doing other therapies at the same time. And there is an on-call system involved because of that crisis model that's built in. And these practitioners, it's important that they see families a lot, especially in the very beginning. MST is built to be able to see families or to be doing this therapy at least, at minimum, 2 hours per week. And it can be delivered in any setting: school, home, an actual office, etc. So in Virginia, it's important to note that DBHDS and DMAS have set workforce requirements for these MST teams. Regardless of whether a provider accepts Medicaid or not, these teams are supposed to include more licensed practitioners and then QMHPs. QMHPs, or unlicensed or license ineligible, I guess would be a legit term, can only make up a third of the team at any given time, 33% or less. So what that means that if you wanted even a larger team, say you wanted not just a team of 3, which that's the minimum, you wanted a team of 4, according to this rule, it can't be 50-50, 2 QMHPs and 2 LMHPs. It has to be 3 LMHPs and 1 QMHP. These LMHPs, it could be a supervisee or resident working towards full licensure, working towards getting enough supervision hours. And functional family therapy. And again, if you have questions about any of these EBPs, because I have 0 feedback going on, I don't even know it's useful. Like, I don't know if what I'm saying is useful. So if you have questions about MST, which I hope you do if you're interested in it, jot them down. Those are the things you're going to send in to me. We'll either answer them through a public FAQ, or we will have a live session where we'll absolutely start with those questions. Functional family therapy. What is this? So this is for 11 to 18-year-olds. Again, this age limit is a little bit flexible, I've heard or I've seen, depending on where you go. So this therapy is really for those families experiencing a lot of discord, so a lot of high conflict going on in the family. And the child, the identified patient, you're seeing some moderate to severe acting out behaviors. Okay, so these perhaps emerging substance use issues in kids, academic failure, learning problems, disengagement from school, disengagement from anything that's pro-social, and real disengagement from the family too. And what is really cool about FFT is that their theory that underlies FFT is that problem behaviors serve a function within a family system. So again, let me stop for a second. MST is about multiple systems in a child's life and how they're influencing a child and how a child influences multiple systems. Functional family therapy is all about the family system that a child is in and the different sort of communication patterns and dynamics that are happening within a family system. I mean, they pay attention to the social ecology because all the therapy should, but really the concentration is there on the family system. So family members develop ways of interacting with each other that help get their relational needs met, but often these patterns can be dysfunctional. So a great example would be typically what happens when the child behaves aggressively to receive attention from a parent who is checked out or not present, which, by the way, children, adolescents do things all the time for attention. That's a completely normal human developmental behavior. All children need an inordinate amount of attention, and a positive attention, especially from many different adults in their life. So that's part of being a social being. So when children are ever interpreted as doing things for attention, whoever is saying that's 100% right, and they deserve attention. So all we can do as adults is be selective in what we attend to in order to see some behaviors more often than others and to see some behaviors less often than others. It's the way that we modulate our attention. All right, back to what we're actually doing. Diagnoses for FFT typically include same things as MST: cognitive disorder, oppositional defiant disorder, substance abuse, misuse, truancy, school problems. Like MST, this model was developed in the 70s, and perhaps maybe even a little bit before that. And what's really important about this one is that therapists are trained, or practitioners are trained to really adapt to the family's values and belief system. It's very process-oriented. What is seen in the room is what gets talked about. The communication interactions, the dynamics between families is what the spotlight is on, and ways to adjust these interactions so needs are still met, but the outcome isn't pain, and the outcome isn't truancy. The outcome isn't hurt. It is you're getting what you need, but also strengthening the family bond at the exact same time. And that's what this treatment is really shown to do, is strengthen the family bond, the family of origin. What's neat about this therapy is that it builds crisis management into the caregiver. So this isn't a therapy you go to that's 24/7 like MST. It's not. It does not have crisis response built into it. It builds the crisis model, how to deal with crisis, into the caregiver themselves, so they can deal with it as it comes up during the course of therapy, as it inevitably does. So families can handle these blowups themselves during treatment. And that also kind of grows their autonomy. It grows, it empowers a caregiver. And that's really what this is about. FFT therapists or practitioners, they reframe things that are seen as bad parts that people don't like about their families, the way they do things. They reframe them to show them how what they're doing makes total sense based on how they grew up, or what they know, what they've learned over time. And we build new ways to communicate and work with each other. So something that's really important about this is the caregiver really must be willing to do the work. And that's why this therapy wouldn't be that great for a caregiver who is not at all interested in attending treatment or really working on the things that are going on within a family system. Here's the training timeline, kind of a real quick switch, but FFT's implementation model, their training model, really focuses on supervisor certification. So internal folks becoming certified as supervisors, so that consultation from the outside transfers nicely into the on-site supervision, because they know, I mean, being a family systems model, you understand like the inside, the in-group, what people are doing on the inside, that's really where like change and good results are going to come from, is when everyone's on board. So 3 to 8 clinicians are trained in 1 year of implementation. You can kind of see that they have a similar cadence like MST does. However, supervisors have this sort of like longer period of time in year 2 where they're under consultation. There's also these live consultation sessions. So versus MST relies on case review, like looking at records and data, a lot of progress monitoring data and outcome data collected from families and from multiple people within a system, to make sure that practitioners are being adherent to a model. Family functioning therapy also likes that too, but wants to see the therapist in action in these consultation sessions. And FFT also requires ongoing contact with the site over time, just like MST, to maintain certification or license of a site. All right, so for practitioners, these therapists who actually want to deliver FFT, this is also, again, a team model. This is a team-based model. So just like MST that I talked about, it's a working group of 3 to 8 therapists, 1 supervisor who must carry their own cases. A family sees 1 therapist, but that therapist consults the rest of the team very often. These therapists are supposed to be seeing a minimum of 5 cases to keep fidelity to the model, a max 10. They found that if you don't stay in that sweet spot, that practitioners often drift from the model and become less adherent over time. And so that's why like the caseloads are so important for these EBPs. They're predictors of adherence and of fidelity. So practitioners who are interested in delivering this, they must be available 60 to 90 minutes face-to-face for therapy, 30 minutes over the phone per week, in addition with families, because you're really helping that system. And that depends really more on need and risk. Treatment typically lasts about 4 to 7 months, longer if the child or a family member, longer if a child is experiencing substance use or abuse. And this is done weekly over time, with session length varying depending on family. Again, very adaptive to the family values and beliefs. Practitioners are requested to be relational in approach and direct, because you are calling out certain things that happen in families that have been happening for a really long time. So it can be, for those who are not used to being more direct, it can be uncomfortable at first. There's a learning curve involved for sure. And therapists who are tuned in to the systemic issues going on that are impacting a family and also leading to the expression of some of these symptoms. People often ask, can you do different models at the same time if you're a practitioner who's been hired to do FFT? FFT doesn't, versus MST, MST wants to sort of, well, let me back up. FFT doesn't want to take services away from a family that are protective factors. So if a family is also getting other stuff outside of FFT, the model says, keep that going. If it doesn't openly disagree or directly disagree with what we're doing in here, then keep it going. That's just extra support. More is better, quality, quantity, whatever. But the FFT therapist also wants to ensure to coordinate these services too, to make sure they make sense with each other and they're congruent. So in Virginia, it's the same exact issue with the licensed. So 2 licensed or license eligible team members, 1 QMHP on a team of 3. So this is for, PCIT is for 2 to 7-year-olds. This is a highly intensive, office-based, originally developed to be an office-based therapy that has a pretty significant setup with like a one-way mirror where the therapist is watching the parent interact with their child, and the therapist, the practitioner, is using a bug-in-the-ear technology, a Bluetooth, to coach the parent on what to say in response to a child's defiance or them not following a certain command. It teaches the parent how, in the moment, how to be predictable with their child when that child acts out in a certain way, and when that child acts out in a positive way too. So a lot of time in PCIT is spent teaching parents how to praise their kid at the right time, which is incredibly important. So this is an intensive live coaching model for caregivers. That's the best way to describe it. Child characteristics, kids between 2 and 7. A diagnosis related to disruptive behaviors is what we typically see. And it's important for receptive language to be above 2 years old. So these are not for kids that don't like to clean their room. This isn't for kids who sometimes need extra time to calm down or alone time in a corner somewhere. These are kids that are being violent at young ages to a scary degree, honestly. These are like severely acting out kids where their safety is at risk, or because they're not listening and they're so incredibly defiant to their parents, they'll run out in the street, or they will hurt other kids or be unsafe in other ways. And that is sort of what is really important about this. This isn't sort of for everyone. This is for, and PCIT is so incredibly intense, and they have the robust outcomes to show that intervention at this age is really what is going to prevent later on juvenile justice involvement, later on legal involvement as an adult. This has been shown to have really long-term and effects for keeping kids out of systems as they age. It's based on attachment theory, meaning it's the relationship between the parent and the child, or the main caregiver in a child's life, that has taught the child something about the world. And what they think and what they know about the world is what is causing them to act out and to be constantly testing environments so that they know whether they're safe or not, or what they can get away with or not. So often kids who are referred to PCIT are kids with ODD, oppositional defiant disorder, any other disruptive behavior disorder, severe ADHD. The belief is that if the attachment between a parent and a child was nurtured and developed early on, the child wouldn't need to be testing environments so often to understand whether they're safe or not. Okay, so the strength of a bond between a parent and child, a caregiver and child, and it could be any adult in a child's life, doesn't have to be a bio-parent. That is what tells them about, it's what tells them whether the world is secure or not. Okay, so we work on developing and strengthening that relationship if it isn't there, and strengthening it if it is. That's really what this work in PCIT is about. It's behavioral, meaning we don't really care about why a kid did a certain thing. We're not going to sit around a room and be like, I think he did it because he was hungry. I think he did it because, he's mad about what his sister said last week. Maybe it's because his dad left a year ago. No, we don't really care about that, because it could be all of those things, and it likely is. We think about the behavior that we can see in real time, and we work on coaching the parents to respond immediately and appropriately in time to either a good behavior by praising it, or a behavior that you don't want to see by either ignoring it or implementing a consequence. And that is why it's so incredibly effective. This therapy is also totally appropriate for children on the autism spectrum. Of course, if a kid is severe and has zero interest whatsoever in social communication, then that's something to think about. But I firsthand, and the literature has also said that this has been effective in children that don't even seem as though they have a social connection or social communication. This has been effective for them. This has also been effective for kids that are hard of hearing, deaf, through different adaptations to how PCIT is done. And it's also been effective for kids in the developmental disability population too. So this is just an idea of showing you what it looks like. You have that one-way mirror where someone is coaching a parent. You ask them to do certain tasks. Because the idea is that you want the kid to be defiant in session so the therapist can see and help the family and the parent problem solve in moment. You want to kind of see that blow up happen so you can empower the parent to handle it. Often parents just do certain things to avoid a temper tantrum. They start to adjust their life to prevent drama, to prevent the chaos from happening. But what that does slowly over time is strengthen that child's response. And they start to learn, this is exactly what I need to do in order to get what I want, because every single time I do this, I eventually get what I want. So you're kind of breaking those associations, and that's really tough at first for kids who are really used to using acting out and their behavior to get what they want. And again, that's just because they didn't have any other way to do that. So they're not at fault for that. So I think sometimes folks, and I probably should say this, folks look down on behavioral therapies, or they think that they are automatically not trauma-informed, or that they can't be used with children who have experienced trauma in the past. And what I would say to that is this treatment has actually been found to be the most effective for children with diagnoses associated with trauma and with kids who've experienced severe neglect and also abuse in the past as well. And this is because we are teaching, or PCIT teaches parents how to reclaim their status as a safe base for their child. We are teaching the parent to respond consistently to behavior that they want to see and consistently to what they do not want to see. And this right here is that means safety to children, and safety means love. So when we teach parents to be predictable again, it allows the child to calm and begin to learn what to do in order to access what they need. They know exactly what they need to do in order to get their needs met. That is the key. And that's why this therapy is so good for multi-child families. So parents that have a ton of kids, when at first they're going to tell you they don't have time to do PCIT, but if you just get them to about 2-3 sessions, they will see it work, and then they will be showing up and they will be doing their homework. It just it may need to be some coordination around kids, taking care of kids and things like that, childcare. So caregiver has to be able to participate in all sessions, at least one, strongly both caregivers if there are 2 in the home. So just some things I want to make sure that we know about PCIT is it's intensive. There's no time restriction. PCIT is based on, again, like a lot of EBPs are, it lasts as long as it takes. Okay, if a parent is still not getting the behaviors they want to see, or if a child is still acting out and being defiant at 6 months, you keep going. And often therapy does take more than 6 months in PCIT. Okay, so therapists have a script, exactly what they should be doing. There's a sequence. The first 5 minutes of every therapy, they are observing and measuring that parent's skill to see whether they've done their homework or not. And how that parent performs in that first 5 minutes dictates what they're going to do for the rest of the session, and it dictates whether they're going to move along to the next module. It's important that there's a language match between the therapist and the family, meaning this is not a therapy to use an interpreter, unfortunately. It's just too fast-paced, and there's a lot of things lost in translation. It has to be extremely quick. Time is of the essence in this therapy, and that is why practitioners have to be super on, probably at all times. This is a therapy that you can't do this all day. You will absolutely burn out. So there is some. It is just an intensive therapy, and that's why it is so incredibly effective. And also, it's important to note that this is not a therapy that is that the program developers allow unlicensed or licensed ineligible folks to do. You have to be in a master's level practicum on the way to getting your license, or you have to be a doctoral trainee also working towards your license. And this has actually been shown too through research, is that what it does over time is that without even trying to make parents feel less depressed. So often what we see is usually, I'm just going to say, are single moms coming in that are so incredibly exhausted with this child, even though no matter how little they are, they're so incredibly exhausted, they're about to pull the plug, like, I can't do it anymore. These are parents who have tried thousands of things in the past, okay, and they've never been found to work for them. And because of all of that, it's just natural that a parent over time is going to be beat down. They're going to have less self-efficacy. They're not going to believe that they can actually do things to change. They're going to believe that the problem is hopeless. And so you often see depression in these, probably most of the time, you see depression in these parents, in these moms. And what we found with PCIT, what's really cool is that depression improves as their child's behavior improves. So without even talking to mom about her own depression, without even targeting mom's depression through treatment, but actually just targeting their kids' behavior, you actually see these huge, significant improvements in parent mood, also anxiety as well, as treatment goes along. So this is good, this is all to say, this is good for baby parents that think like, I don't want my own treatment, I just want to help my kid. Great, we're on the same page. And they'll also feel benefit. All right, so the training is intensive for PCIT. This blue bar right here keeps going. You just can't see it after this key. But consultation, which is weekly meetings with someone on the outside, an expert in PCIT, is happening weekly for at least a year, and usually longer. I know there's different cadences, different routines, but this is basically what we see. And there are multiple periods throughout training where you must show proof of competency, meaning sending in videotapes for your consultant to look over and work with you on in the next session. You have to turn in actual like measurement. At the end, when you want to get certified, you have to turn in all your paperwork. So you have to actually have people observe you in real time as well. And you also have to take an exam. So there's multiple different pieces to make sure that you're doing PCIT the way it was developed. And this is probably also why we're able to see the outcomes that we do in the real world, because of the intensive sort of requirements of training and of becoming certified in PCIT. There's nothing here for supervisor, because clinicians or practitioners are often trained individually within systems of care, within their actual provider site or their clinic setting. And this hasn't shown to be the best for staying in and completing training, and then also being adherent to the model later on, because PCIT is often so different from the status quo. But usually when you're doing something different within a clinical setting than everyone else, you're not likely to keep doing it. That's just human nature. We're social beings again. So I think over time, people are realizing that you need this extra support, like a mid-level manager who's also receiving some consultation that's less intense as a practitioner, but ongoing. And the leadership needs to also be trained to be able to support folks. There are ways that you can build in a within agency trainer down the line, but it totally depends on whether this practitioner has been trained to full certification. And then you can start training them to be a within agency trainer down the road as other practitioners start to populate a clinic. All right, so here's a word on rates. I'm surprising you guys instead of going to the next EBP, but we are at a stopping point where we just talked about the first 3 EBPs that have been in Virginia for quite a while. So these are not new to Virginia. Given what we've learned in the first year of implementation of these EBPs, we as a center have decided to no longer set EBP specific rates. There are a lot of reasons for this. Briefly, this is because access to Title IV-E is highly dependent on the health of a locality's FACT and their CSA. Local DSSs must be referring cases eligible, and they must be doing all their due diligence before a case is even referred to FACT in order for Title IV to be accessed. And because we know that CSAs contract differently across the state, they have different rules, different sort of requirements, it's likely that the same reimbursement rate, so if we try to set an enhanced reimbursement rate for a certain therapy, it's possible that in areas where there's a ton of other services, some evidence-based, some not. So a higher enhanced reimbursement rate is advocated, but we want the providers to set that themselves because every environment is different, and what is competitive in one place is not going to be competitive in another. All right. Lots more I could say about that, but I don't know if that's what we want right now. So questions to come, please ask them. All right, so here are our new Family First Virginia EBPs. Now we're going into the fun stuff. Again, this is to show you all where these new ones sit. So BSFT, Family Checkup, and Homebuilders, all 3 of these new ones have a much larger age range for kids, so hopefully they're more applicable. And we did this on purpose because we want them to fit into pre-existing service arrays, which differ significantly across the entire beautiful state of Virginia. BSFT, Brief Strategic Family Therapy. This is the one that we spent the most time on implementing at the very beginning of 2022. Whoa, 2022. This is for 6 to 18-year-olds who are using substances. And this is also for teenagers. They don't have to be the ones using the substances, for their parents too, because treatment for parent substance use, unless they need detox. But even, actually, I'm going to stop there. It also helps the parent, alcohol use, drug use, and also while it also helps with child too as well. This therapy is good for emerging disruptive. So before a kid gets to the level of like an MST situation. And it also treats depression and anxiety. So kids with internalizing things on the inside going on, it's good for them as well as for acting out. BSFT is similar to FFT in that they believe that the problem is serving a function within a family and that family dynamics actually drive and maintain dysfunction within the family. BSFT has been called by the actual developer of FFT to be FFT on steroids because BSFT does what FFT does, plus the addition part of restructuring actual communication patterns within families, if only attending to process at any given time. So when families come in, they do not talk about what has happened in the past. They are not really encouraged to talk about what caused a fight last week or what made the parent mad this morning. They attend to what is happening in session in real time that they can observe. And the therapist is supposed to be very direct and jump in to show, you know, when you do this, this is what happens. Try it this way. Let's just try it and let me watch. So it's a lot of modeling, role-playing, asking people, the entire family, to practice new things that make them feel uncomfortable in real time. A child could be called into a family session regardless of their willingness to participate from the beginning. The practitioner, through the process of joining, will work to ensure the child is heard and understood. The child's first interaction with a BSFT practitioner could be directed by phone. That's totally fine if they're resistant to join the meeting. The therapist or the practitioner learns patterns potentially responsible for these child system during the very beginning of treatment. And that's why those sessions at the beginning can be longer. They're not restricted to like just the hour. Sometimes sessions can be 20 minutes because that's all that a session needs to be for that week. And sometimes it can be an hour and a half. So what's really Oh, what's really beautiful about BSFT, I would say, and the reason why we went with it as the first one is not only because of the amount of structure that the purveyors provide and they want to see, but also because they have an alternative diagnostic system. So they do not use traditional diagnostic labels. They diagnose the interactions between family members and ways to go after ameliorating or transforming those interactions. Let's see, sessions can occur more frequently during crises, but part of this inherent to this model is that independence of a family system is really what we want to work towards. Therapists are not on call. They're never wanted to be on call. That's not part of the model. We want to empower the family to sort of handle their problems once they learn the skills to do so and to practice them in real time when there are problems that arise. And also, yeah, that's good. So BSFT is pretty picky about that they want this to be the only juice that a family is drinking. The family cannot be receiving other therapies or other things going on at the same time because BSFT is so process-driven, they're theory-driven, and this is what they have found their best outcomes when families are only receiving this. Again, marital problems, so issues happening between the adults in a household, a parent's substance abuse or substance use, misuse, all of that is solved in the room, in the vessel of BSFT, in addition to the child's problem too. That's why the entire family is seen as client. So families should expect to learn, and here wasn't one more. Yep. Also, BSFT has a strict intake procedure as well, where the person that is going to be the assigned therapist for a family cannot do the intake. Just part of their model. Let's see if there's anything else about here. Yep. So treatment usually lasts about 3 to 6 months. That's the length of treatment. So it's really seen to be short term. It's unbounded, like I mentioned earlier, by the typical session hour because they really are adapting to what the family needs. This is shown to work, even though it doesn't really work well with our current ways of billing and reimbursement. And there is a lot of work yet to be done within that area, but this is what has been shown to work. And so let's see, when therapists are working within an office setting, the typical caseload is about 15 to 20 families. When they're doing this therapy within the home, it's a caseload should have about 10 to 12 families. But that is what is recommended. During training, it's much lower, like just 2 or 3 families. And also you can do part-time. So BSFT therapies is not like MST where you have to be dedicated only to that therapy. BSFT therapists can be part-time. All right, so here's our training timeline for BSFT. So notice here, there isn't a supervisor yet. And that is because until practitioners meet competence, which there are ways that they do that, then one of those practitioners becomes trained as a supervisor. And I will tell you though, as a BSFT supervisor, internal one, I'll tell you though, the bar for competency is very high for practitioners. So typically what the purveyor for BSFT will say is that it takes like 4 to 6 months of consultation and workshops, multiple different workshops spaced out amongst that to be able to become be a fully competent practitioner. What we're finding though in Virginia is that for our group of practitioners, for whatever reason, this consultation period is longer and it is more intensive. So this is 2 to 3 hours per week of consultation. And there's also this requirement where practitioners in training must videotape all of their sessions. That is a huge deal for people, and it's a huge learning curve for clinicians to feel comfortable doing. There's a lot of things you learn of how to talk about this with families, how to get consent for that. Again, families are not really, they don't have to be in the camera, but it's really about live out so that consultants can watch these videos and really just very much know exactly what's going on in session, so they know what to talk about in these consultation sessions, so the training knows exactly what they need to do. So this burden of proof is very high, and we've been finding in Virginia that it does take people longer than 46 months to make it through this training. And only then can we start talking about sort of a supervisor for the site. The provider site also receives training and requires a proof of competence like site visit. And so after people get trained to be an on-site supervisor, that trainee will show the competency board their mastery of BSFT principles in order for the institute to confer upon them the title of BSFT supervisor. And then there is ongoing contact even after people reached certification. Adherence is maintained at a yearly level following that structure. During the first year, the clinician will receive 6 adherence sessions. First year after the first year of training, 1 every 2 months. During the second year, the clinician will receive 4 quarterly sessions of consultation. During the third year, the clinician will receive 1 session every trimester thereafter. Then thereafter, clinicians will receive 1 session per year, and this can be customized as needed. Clinicians will or practitioners will undergo the competency panel every single year to make sure that they have maintained their skills. So high bar. Okay. Done with BSFT, we are moving to family checkup. Okay, family checkup is the second one that Virginia has been rolling out, and most recently, the one we just rolled out at 2 sites, beginning in the very beginning of 2023. This therapy is specifically for 2 to 17-year-olds, so huge range right there. And this is for families who are most likely to drop out from any type of typical therapeutic treatment. So these are the disengaged caregivers, the ones who really don't look motivated. And I say that because that's just what is interpreted, but there's lots and lots of reasons for this that likely have nothing to do with them loving their child or not. They're just disengaged from these systems. So the child is acting out in school and starting to have these academic problems where they are similar to what, like what we see with FFT for these kids, but younger. But this can be done with younger children. And again, kind of like the other models that we've talked about, family checkup respects the child's ecology, in that there are all these different sort of influences happening on the child, and that all of them really need to be assessed and attended to really help the child and come up with a treatment plan that is going to work. Family checkup is first and foremost an assessment consultative model in the very beginning. The first 3 sessions, the first 2 to 3 sessions, this is where an assessment is conducted with the parent and the other adults in a child's life. So what that means is it's similar to case management, where the practitioner is working with standardized measures and collecting these measures from multiple reporters within a child's life, including the school. And then there's like a feedback session where the practitioner meets with the family, like a consultative, like business model almost, where it's like they incorporate video-based feedback from family interaction tasks. They ask parents to do certain things. And in that feedback session, they show them, say, you know, you did this, but we're thinking that this is the way that it needs to go. They're developing a plan together and looking to the parent to be the expert in deciding what they're going to do next. So family checkup is this assessment consultation model. The therapist or practitioner comes up with a menu of options or recommendations, and together with the caregiver, they determine what they want to do. And those recommendations, that menu, can include everyday parenting, which is the positive parenting skills module of family checkup. So they could refer to themselves. Sure, I mean, that's helpful if you don't want to like go to another provider, but you can also be like, there's also these other issues going on in the home. So how about we do these other support services in like simultaneously while we continue with parenting skills training. Motivational interviewing strategies are the key process skills for feedback delivery and for engaging parents. The caregiver and the practitioner, they collaborate to set goals, and which usually often is attending to strengthening parenting skills. And the program has been adapted for telehealth and tested that way to enhance accessibility. There's also some like other tech things that they do to help with parent engagement, like text messages and an app. And what's important about this treatment is that session is capped at 15 sessions. So that helps you with your planning and helps providers, we found, with their planning in sustaining this model over time by understanding how much to budget, etc. Oh, and this just is kind of showing you an empty template of what these assessment meetings look like. They have data. They show you how the child sort of matches up across reporters, according to teacher, according to you, according to child themselves, to really understand what is going on here. What do we need to work on? What is the root of this in order to know how to move forward? And this assessment piece is often missing in traditional treatment programs. It's usually done really quickly through an intake procedure that's very informal and doesn't include standardized measures. This, they really put a lot of energy and time in doing an accurate assessment in order to know what we need to do. All right, so the family checkup training timeline, I would say it is less intensive than any other of our EBPs within Family First Virginia. I would say maybe it's at the same level of Homebuilders maybe, but I actually think it's a little bit less than that. Certification is supervisor dependent. So practitioners do not receive certification because you must be, because for a site to be certified, you must have a team with a certified site supervisor, meaning all of those words that have S's in it, all they mean is that family checkup, the purveyors who are in charge of training folks in this, really, really want to embed a self-sustaining supervision model. It's part of their training. It is inherent to how they do it. They don't just go after practitioners to train practitioners one by one and try to get them to competence. They are in their mind always thinking about how do we make sure that we build in supervision to this place so it can be self-sustaining over time. And FFT is similar in that way, but I would say family checkup goes further. So 6 months is the total time in training on average. E-learning modules are in the very beginning in this workshop situation. E-learning modules followed by a skills practicing workshop or webinars, plus consultation hours throughout the first 6 months. And in those consultation models, you'll see over here, you'll see that in the consultation models, it is up to the practitioner to videotape their sessions, and it's up to the practitioner to show those videotape sessions to their consultant. So right there, that tells you that Family Checkup really values the relationship that these practitioners form with their consultants, their external consultants. And so they feel as though they can be honest in these sessions and really talk about how that treatment is going and be willing to be vulnerable, because training as a therapist it can be extremely stressful and feel very, can feel like you're doing it wrong all the time. So people are more likely to close up. Again, time to certification varies by candidate. Consultant time, never mind, I don't need to go into that. So after practitioners are trained, from the group of practitioners that have been trained, you select a supervisor, and that's why this right here says supervisor plus. So whoever was selected to be the internal supervisor has to go through some proof of competence activities, meaning just showing the consultant that they can go above and beyond and do that consultant work too. Then they go to their own workshops, and then they have this intermittent consultation, which this process right here could look a little bit different than this, but this is the basic overall picture, that there's these quick touches to make sure that someone is staying on track. Recertification is required every 2 years. You submit videotaped sessions for review by a family checkup consultant who scores them with this fidelity tool. So you just send the videos to maintain your certification. Bachelor level folks are totally okay, according to Family Checkup model, to be providing this EBP. But prior experience practicing motivational interviewing is absolutely essential. And if practitioners do not have education or knowledge in motivational training, this will be detected within the first workshop, and there are additional courses and modules about motivational interviewing tacked on to someone's training trajectory, their training timeline. So there'll be extra. And that just really shows you how FCU is taking the extra bit of adapting their training to site and what sites need. So 2 weeks after after workshops begin, we have 1 hour of 1 hour of group consultation per month. Okay, so that's important. That's different from the other EBPs where the consultation is happening weekly. And that's per month for 6 months. I think that's all I want to say about that. All right. Homebuilders. The last one we are talking about is for all of the kids, 0 to 18. So because this is really a stabilization model, people call Homebuilders has been around forever and ever and ever. It's often gone under the name Intensive Family Preservation and Reunification Services. It's been called that before in the past. And the reason why we chose this is because it's tried and true. It's something that has been within the ether for a long time, and it has good data to show that it helps with stability of keeping kids, whether it is going to a better place to live, like if they determine that living in a place is just not safe for a kid, it's shown to help with stability there, but it's also shown to help with stability in the family of origin as well, by helping the family inject and embed structure and certain routine into that life, so the home environment becomes less chaotic and less unpredictable and unstable. Because that's really what the essence here is, that the family is always in a state of constant crisis. And these families that don't have access to Homebuilders are just most likely to end up in residential care or an emergency department over and over and over again. So this is good for areas where you're seeing a huge overuse of residential services. This is a good thing to put into place to start to build a service array. It is a type of model that believes that crisis is the perfect moment to intervene, because when things are in disarray, that is when they are most flexible, and that is when they're most malleable. So when you intervene at the right time and you have the right amount of continuum of care, not just like a quick touch and leave, or just like a stabilization and leave, but if you're able to stay there and help rebuild the family, they reintegrate into a structure that is much more stable and resilient and robust, so they can kind of withstand issues that happen down the road. So they really see that point of crisis as like a perfect time to intervene, but they're not just going to intervene and stabilize. They're going to stick around and make sure that you're seeing benefits and that crises aren't coming back up. This is a longer term crisis model in that it is 4 to 6 weeks length of time, and the family is getting a lot of attention from the practitioner at this time. They have 24/7 access. And again, I said earlier, reduces the need for residential. The interventions are that the actual practitioner is doing with these families. It's like direct teaching, it's role playing and practice. So you're seeing some of these behavioral things coming in, coaching and prompting. It's assigning homework for families to work on between sessions. Common skills that are taught to parents include how to praise your kids. So a lot of behavioral stuff that we're seeing in other cognitive behavioral things, positive attention, giving clear instructions, expectations, contingent consequences, how to make sure that rewards are tied to the behaviors that you want to see in the home, and teaching kids how to be assertive about their needs, to advocate for themselves in school, to problem solve effectively. So there's that cognitive piece where they come in, where they teach families skills on how to actually look at a problem, to define it, to take it apart, to begin to look at it and solve it together, and collaborating with other providers, using how to access other community services, and then advocating for yourself for those community services. So in Homebuilders is like cognitive behavioral therapy plus economic support and economic stability, because there's also financial supports that are provided to families through the practitioners doing Homebuilders. Let's see. You're really, through this model, Homebuilders, the intervention components are attempting to promote safety throughout. The intervention assesses family safety constantly and developing safety plans constantly. And the goal really is to structure the environment so the family system is preserved and it's stable. The kid can stay in that home. That's really hugest goal, is just stability. Yeah, I think I've said what I need to say there. I'm trying to think if there's anything else. Oh, I will say that a practitioner is usually just working with like 2 families at any given time, because they are dedicating up to 20 hours a week per family. And so if you're part-time, you may just have 1 family. You may not always need to be dedicating this much time to a family every week, but in the beginning, if they're in crisis, it's likely that you will. And so often intensive in-home models or intensive in-home service categories, this is a good EBP that would fit into an intensive in-home model, since those folks are already doing things in folks' homes for that about 20 hours a week, if not more. And however, intensive in-home, the service category itself in Virginia, nor in other states, has any sort of guidelines or principles for how it's supposed to be allocated or delivered, when this is an EBP that actually absolutely does. Okay, so Homebuilders, the people who train this, is the trainers is a nonprofit out in Washington, I believe, or somewhere over there, Oregon, I don't know. They develop sites, but certify therapists, so therapists can become certified. The site is not licensed anymore if therapists leave. Okay, so there is that sort of like, what is that codependency sort of forced to happen between the practitioners and the provider, because we don't want to lose the people that you invest in training and that we invest in training too. So they really do care as well about a supervision capacity building model. They want practitioners to become supervisors. So right down here in the diagram, you see that practitioners receive a workshop, and then they go there in weekly consultation. If you want to become a supervisor, then you also have your own weekly consultation after being trained at the practitioner level. And there's another series of workshops specific to supervisors. You must start at the practitioner level like other EBPs. And that beginning workshop here is like a 10 to 12 days virtual online, where you are grouped with people, other practitioners training from other states too. So it's an online situation. Weekly team and individual consultation. The consultation period for the supervisor in training is long. It can span past the first year. It can actually span more than that, multiple years. Once the site supervisor has been determined to be able to do their own fidelity monitoring for the site, then consultation is more on an as-needed basis. And consultants are assigned to site, and they're always available 24/7 to the practitioners in training or the supervisors in training. And they really pride themselves on providing that scaffolding approach, that they are providing a lot of support that they slowly titrate away from as the site becomes, their capacity builds to be able to do their own fidelity monitoring. There's no videotaping in this kind of therapy. There's no exams like that, but there are case record reviews. And I believe that sometimes they try to come on site and shadow some home visits. But there's a lower threshold for burden of proof for home builders, which people like because they're not really in your business as much. All right, so for home builders, for practitioners, teams, this is another team-based, which again makes it a really good thing to adapt to, really good for an intensive in-home model to sort of use this as a model, to take this as something they're using to guide their practice. Teams consist of 3 to 5 practitioners. The supervisor in training eventually, that's going to become that, and on-site, as well as an on-site program manager in addition to that team. All right, so this on-site program manager, that's the administrative person, like I said earlier, incredibly important. So services are provided by a single therapist with the clinical team there to back that person up. In rare circumstances, more than one therapist on the team will serve a family. But that on-site program manager is essential because they are the person that will need to be on call and be able to schedule intakes within 24 hours of a family reaching out. So when I say 24/7 access, this isn't, Homebuilders is not they're not going to drive out to meet you in the middle of a crisis. It's possible places could eventually move to that if they wanted to. They would have to work with the purveyors to figure that out. But really, this is a 24/7 access to being able to schedule a 24-hour, an intake within 24 hours. So the crisis has happened, but you need to get in immediately. So perhaps maybe this is a good idea for providers who are already working within a crisis response model to use as a way to sort of then have a continuum of care right after that immediate crisis is stabilized, to immediately go into Homebuilders if this is a family that's likely to go back into crisis very soon or within the same month, within the same 6 months, etc. So, 48 hours at the latest of being able to see them immediately. And I will say that the developers of Homebuilders are, and this is what our representative said, the purveyor, is that they are anti-license. They believe that bachelor level practitioners can do this service just as well as master's level. However, bachelor level must have 2 years of related experience in providing this kind of support before going into training. Let's see, for a full-time practitioner, that person will be averaged to see or estimated to see hopefully 18 to 22 families per year. You work with 2 families at a time. Like I said earlier, max. Families typically receive, 40 or more hours of face-to-face contact during the entire intervention, the entire time, but this can vary greatly. Lower caseload expectations, so a full-time are better. So a full-time person will be 30 hours sometime. Well, so if you have a full-time person, it's totally fine, and you should expect for them to just be working 30 hours per week, because some hours will require 40, if not slightly more. So it's not going to even out perfectly every single week. So that is why you want to have a lower caseload and not try to pack someone's caseload out to where they're constantly burnt out by like high need families and working at 40 hours or more a week. So providers, this is something, I'm saying this because this is something that providers can do to support their staff, which is absolutely essential in receiving additional funding past the year 1. You show us that you are doing certain things to make sure your staff don't burn out. And we can help with that too. Let's see, full-time employees can be doing Homebuilders half the time and something else the other half the time. They're flexible in that way, the purveyors are. And so they can provide other services as long as they remain available to their original Homebuilders family. So unlike other EBPs that kind of require someone to be dedicated to that EBP, Homebuilders has a flexibility in that. And again, program lasts 4 weeks or up to 6 weeks, which is considered an extension, with boosters available 6 months after the service ends. So we've talked about all of these things. Now, the reason why you're probably here. Okay, so how do you get this money? How do you get the training award? So these trainings in the first year can range from, let's see, $15,000 to $70,000 to $80,000 in the first initial year of startup, depending on the EBP, because they all have different things that they offer. Every purveyor does more or less. They have different prices. So any EBP, and it's not just family first EBPs, but any EBP takes a considerable amount of investment and dedication in that first year and in the years that follow, honestly. And VDSS is committed to being able to invest in sites, so they're there for the long term. And we're doing this through 2 different ways. We're doing this through the supplemental and full awards. So what I'm about to show you, these steps right here, is for a full award. So this is if you've never given any of the EBPs we talked about, and this is going to be your very first time. You could have done EBPs in the past, and that's totally fine, but this is the first time you're going to do this EBP, and so this is how you apply. Step 1, you go to CEP-Va.org, don't forget the dash, and you'll see there's a link to something called Qualtrics, and all that is a fancy survey site that VCU allows us to use that collects some basic identifying information from you, the provider, and about your site. So we want to know things like, what's your service coverage area? What's your relationship like with your local CSAs? What's the insurance that you take? We want to just know about your site, because we know through the evidence, the literature over time, that there are certain things about sites that make them more likely to be successful at sustainment down the road. But all of these different factors need to be looked at within the context of an environment. So, sorry for going back. You complete this first step, which is just going to probably take you, I don't know, less than probably 10 minutes, the provider, to fill this out, and you submit it. That gives us an idea that you're interested, because this second step, We broke up the application on purpose because this second step takes a little bit more time, and it's likely that people need help. And that's totally fine because that's what we're here for. And we'd rather help you do it the right way versus spinning wheels and getting frustrated with the process. This step 2, providers are required to submit 3 different things, okay? First one is a demonstration of need. This is just a Word document that you write up to tell us why you need this service. And we are looking for very specific things, okay? We are looking for local data, okay? That is the way to honestly get funded, is if you just put some local data in there. Show us that in your specific area, in your community, you're seeing X amount of X type of problem. You're seeing X amount of this, you're seeing X amount of that. Data from, outcome measures is beautiful. You can just look at, population-wide data, whichever, but show us that you put some thinking behind why this particular EBP, not just any EBP, but this particular EBP is a good fit for the people that are showing up at your door for services, okay? That this would fill a certain service array that is, this would fill a gap in the service array of your entire community, okay? And that last part is kind of important. It's not that we are interested in filling out the service arrays of individual providers. We are interested in filling out the service array. So there's a continuum of services across a care continuum of severity that is available within a community. And so a provider may just contribute to pieces of that. And so it's important for us to see that the people who are submitting their applications for these awards have looked outside of their own business, company, entity to see what is really needed in their community. What services are lacking? Where are the gaps? Okay. And we want to see that you know your community, because we know that there's a capacity for you to know your community so much better than us. And that's really clear. Okay. We also want letters of support. Letters, well, one is required, but you can send as many as you want from your local DSS folks to show that they have a working relationship there, that you've told them about wanting to apply for this grant, and that you are dedicated to accepting their referrals. So a letter from them that shows that they support the work, they support your application, the materials, and that they would use the service if it was available in their communities. We have a template online, so don't worry, we're not asking for them to write you a rec letter, recommendation letter, or to write their own demonstration of need. We have a template they can simply use, fill out their name and signature. And then we require you to send in, from your local DSS, we require you to send in a training matrix, meaning just like an estimate of who's going to be trained and other details about these practitioner employees, so we can begin to build out and plan for how much capacity is needed from our contracted purveyors in concert or in context of the other trainings that are happening at that time. Okay, so something that people have run into is that often people will quit maybe in the month after they submit their application and before we actually talk to them, or they quit by the time of training. That's fine. We know things are going to change. We know that we have a workforce crisis also. Isn't it amazing that I've done this entire presentation without mentioning that once? But we just want an estimate. We just want like a basic idea of what we need to be planning for support-wise for your site. And yes. Okay. And then you're going to send all that stuff in that step 2 to ebplab@vcu.edu. Okay. You're going to email it that. If you forget, that's fine. We'll email you and remind you because we have this first step. So again, let me review how to apply for a full training award to get money to cover. Well, I'm about to tell you what it's going to cover, but you have to do 2 steps. 1, complete an online form. You find that at our website, CEP-Va.org. Don't forget the dash. Then after you submit that form, you need to email to us, ebplab@vcu.edu, 3 different things. It could be all in one PDF. It could be separated. We don't care. We just love to see it. Send those things in. If you send in a form, but then wait like 3 months, I think we set it at 90 days to send in the rest, you're going to have to send in a new form because we know things change. So the timeliness of those 2 things putting together, and we'll help you with that. So we know that you've already submitted interest through step 1. We'll help you make sure to get those things together if you need help. I believe also a graduate student within our lab is working on a way for us to collect these 3 things through a Google form versus you having to email it, but all the same, you could email or use this Google form, we're really not sure if that's going to make people more likely to turn these things in. I think everyone just will require a certain amount of support because this is new, and we're taking our time with finding sites and making sure these things are being put in places that they fit. All right, so what is included in these training awards? Like, what are you even applying for? Why should you care? I will tell you, we will pay for all of the workshops in year one. We will pay for all of the consultation requirements that are made as requirements set by the purveyors. The purveyors tell us what is absolutely needed, and we pay for that. We pay them directly. We pay for all certification and licensing fees, access to online documentation and resources if they have that. We pay for manuals, technical equipment if you need it, meaning videotapes if that's required, meaning toys if that's something that's needed to have to keep fidelity to the model. Yes, and again, if you are already doing PCIT, FFT, MST, you can submit a supplemental award. The link is also on our website, and there you can ask for these extra things. You can ask for extra training for new practitioners. You can ask for extra consultation, extended consultation for practitioners that need a little bit of extra boost. You can ask for payment to put in a one-way mirror in your clinic, or for toys that are being used within the coaching parenting sessions, for manuals, for materials, for Bluetooth technology. So please, your creativity and your imagination is the only limit to what we will fund, because we really want to be able to make sure that these things stay. VDS is absolutely committed to investing in providers who wish to build a supervisory infrastructure that is self-sustaining and eventually able to train new practitioners to competency on site within the state of Virginia. So VDSS is willing to fund training to site certification standards, as well as cover additional years to the greatest extent possible. So that's important. Funding past the first year depends on level of provider engagement with the center and or the EBP purveyor. It doesn't just have to be us, but it has to be someone within our team, our implementation team, during initial training and implementation. I will say level of engagement. The reason we're saying that, and not, how many clients you're able to see, or how much the extent of fidelity to a certain model within the first year. We're not basing, or other things that providers cannot control. The reason why we are basing funding decisions on level of engagement is because there will be huge barriers, as there always are, to implementing something that is structured and made in a place separate from the environment in which it's now trying to fit into. Okay, so you're going to get people resistant to people who are not buying into it. Clinicians who thought at first they wanted to do it, but no longer interested. You're going to see problems with referrals in the very beginning. We are going to try to help you plan for these things to prevent them from happening, or mitigate them from derailing us, but there will be problems. And the worst possible thing that can happen is if a provider feels as though, which often happens, that it's all their fault, and they begin to feel as though they're going to be blamed, and they start to kind of close up and don't respond to emails and things like that. And we want to be very clear that we are here to support anyone who is interested in trying to do this. Even if you determine at the end of our EBP funding info session or meeting we have together that an EBP is not right for your site at this time, call us in a year, call us in 2 years if we're still here. We just want to work with those who are interested in actually seeing improvement in families. And you don't have to have a fancy degree or have done EBPs in the past, or have all the knowledge in the world of how things work in your community to be able to do that. Okay, we will work with you and help you to do that as well. And we learn from each other throughout the process. And this is just a quick sort of look of the different phases within our partnership engagement model. So in that first, you'll see right here in number 1, the first phase is that fit assessment, and that's that RFA process that we just talked about, the 2 steps, the Qualtrics portal application submission, and then the 3 things, a demonstration of need, letter of support, and training matrix. So that's our RFA process, assessing fit. We have an EBP funding meeting immediately after you submit your application. We can also have one before you submit it. It's really just so you understand, or so you get questions answered. So then you can make a determination on whether you should put in the time for an application, or whether the one that you put an application for is maybe not the best fit, and we can start thinking about a different EBP that could be a better fit, and we had that conversation. We provide technical support in this first phase. And this phase can last as long as it needs to last. We move at the speed of trust, period. It can last about 3 months. It can last about 5. It really depends on the speed in which the provider wants to go. Partner process is this second phase where, the provider, you decide, hey, we want to do BSFT. We are ready to go. We are all in. Then we say, cool, I'm going to write up a training plan and a payment agreement. The people who will be reading that plan and have roles named in there for them specifically are VDSS, the funder, us, the center, the provider, the awarded provider, and the purveyor, the EBP purveyor, which changes based on EBP. And we all have a meeting, a finalization meeting, where we talk about that training plan and payment agreement, sometimes rip it apart and rewrite it so it is not perfectly, but it is tailored to that site to where it's actually going to work and make sense. And this document is it is written in real words that real people can understand, because I wrote it. And then we procure the purveyor, because every single site that is going to receive training has their own purchase order. So we work with the purveyor and VCU to get that done. And then phase 3, once we get the training plan in phase, everything is finalized. That is when we have the purveyor calibration meetings. We have site execution meetings. We're meeting weekly up into the very first training event to make sure that site is ready to receive that intervention, that people know what is coming down the road. And then multiple training events happen there. And then the last phase that we have with our partnership is this process monitoring. We look at how things worked, what didn't work, what can be improved. And we have a 6-month mile marker. We all get together and say, is this viable? Are we going to throw it in our hats, or are we going to kind of keep trying to go with this? And we have a real conversation about that. So that is all I got there. I'm sure I wish I could know what's going on in people's heads that are actually listening to this. Here are some tips for providers. Local data, I'm writing that again. Show us that you care about your community and know about your community, because we know that you do, and we know that you do. So show us through the local data. We also want to see within this demonstration of needs a capacity for an internal supervisor. If you just want to train like 2 people for a full EBP, that's not going to be super exciting for us, because we just know how attrition is usually to be expected. Clinicians, there's always going to be at least one clinician that drops out after training begins. So you do want to see that you're interested in really committing. Your site is really committing to doing this EBP. So we want to see that there are actually people there that can be eventually tapped to be a supervisor, so it can become a training hub over time. We want to see that you have administrative support that is willing to give some time to working with us to make sure that things are going smoothly. And I don't mean a lot of time, I mean like 1 hour a week to where they can dedicate, or 1 hour every 2 weeks. And this will go up and down, and sometimes not even be required. But all of that is talked about within these training plan finalization meetings and EBP funding meetings. We want to see if you have CSA contracts in place, because we know some CSA contracts, there are certain times where you can submit a contract or update a contract. And so if you already have those things in place, that means your referrals are going to flow easier. There's already going to be a path there that Title IV-E can also then flow through as well. Because again, Title IV-E also always has to go through FAPT, or whatever multidisciplinary team setup that LDSS is set up, but it has to go through a FAPT, which likely means that it has to go through CSA too. Because we also want CSAs to be paying for these services as well, as that will be the only way that we can sustain these high quality services in any given location. We also want to see if there's pre-existing relationships, and we want to see sites that are interested in supporting their practitioners so they don't get burnt out and that their time is compensated appropriately. And other things that will lead to funding down the road, maybe not like initially, but funding after year 1, is this willingness to expand coverage geographically. So being able to match the CSB catchment areas that you're in. So one CSB can always rely on sending referrals to you versus a CSB having to think, okay, well, this locality is covered by this provider. So if the person lives in this locality, we can refer. But if this locality, that provider doesn't, it's not available there. We don't want that to happen. That's sort of a side effect of Virginia that really makes services quite fragmented and very confusing for a lot of folks. So if you're willing to cover an entire CSB area to where you are always an available service for that entire CSB, we're more likely to fund you past year one, 100%. All right. Whew. We are almost done, and this is 2022 in review. We've learned so much in this last year that has really influenced the way that we're going about these things, really realizing certain systems that may or may not be in place to sort of nurture and support EBPs. And that really was what our last NAGA report was based on, which will be accessible through our website very soon, if not already by the time you read this. We found in NAGA 1 that we needed a starting place of where to start implementing these services. And when I say NAGA, Needs Assessment Gaps Analysis, that's an annual report we put out every year that looks at the service landscape and ways that, or things that we need to attend to in order for these services to be available years down the road. We're looking specifically at things that have the power to completely ruin a chance of a practice really being taken up within a certain community and being part of that service array. So we just started with foster care entry rate based on, what these services are supposed to be for. And we saw across Virginia that children living in the Western region over here in Virginia, as well as this other region, more Northern and Piedmont, were more likely to enter into foster care, to be taken, to remove from homes than children living in other areas of the state. So we knew we wanted to concentrate our outreach and advocacy efforts to certain areas within, certain localities within these regions, or at least begin to figure out what's going on there. Also in that this first year of implementation with the center, we really prioritized CSBs. So if you were a CSB that applied to us for a training award, and you did not hear from us, please, right now, email me 100%, because we, every CSB that submitted an application or request through email, we very much hope to attend to and fund if that was something the CSB was willing to do or could do at that time. Again, we know that they faced severe staffing limitations and still are from COVID and other things that have been happening in the state. However, so we call it the CSB Reinvestment Initiative, and this was CEP-Va's first formalized attempt to combine the interests of two child-facing agencies, VDSS and DBHDS. Outreach via VDSS and CEP-Va led to a series of meetings with CSB leaders and program managers. And again, undeniably, CSBs have recently undergone several challenges and significant changes as part of CEP-Va initiative and Medicaid expansion. And many of the CSBs reported not to have the staff eligible for training, and that much of their capacity had been shifted to crisis response. However, we did get a few people to bite, and that was great news for us. I believe we provided funding to 5 different CSBs throughout the state, in addition to providers who worked with CSBs. So this is a look at what has been, as of April 2023, so when this is being recorded, this is a general idea of where services are purportedly available for referral. So people living in these localities that are in blue, BSFT is available to children in that community, to families in that community, based on the coverage area of the sites that were awarded and currently undergoing training and consultation, training, workshops, and consultation. So the blue area is BSFT only. And then family checkup is in that pink, is available in those pink localities. And then both BSFT and family checkup are available in the purple ones. And again, this is an estimate. We know that state level sort of analysis and maps of where certain things are available doesn't often match what we see on the ground, and it often doesn't match whether these services are accessible or not, right? Available is just, it's there where you can make a referral to it in your community, but access really is, can you actually get there? Can you actually show up for the intake? Can you be sustained? Can you stay in that service? Are you retained within an actual treatment episode? And so access is different from availability, but these maps show us an idea of where these services are available. And it's important to contact the providers that are providing these services if you'd like to be able to refer to them. And we aren't naming them right now, but you're welcome to reach out anytime to VDSS or the CEP-Va team. And pretty soon we'll have a directory that you can access to know exactly who these providers are. We also provided supplemental funding. So these are these tinier grants to 2 FFT teams. And you can see where those are located as symbolized by a man or a person stretching. And then we also helped infuse some funding into pre-existing PCIT programs in different parts of the state as well. So if you look back over the year, we're thinking we tried to really prioritize certain areas. And I will tell you that this is kind of what we were able to do after almost a full year of doing that, in that some services stick in certain areas and some absolutely do not, despite all of the effort and making it so. And again, not to beat a drum that everyone has been hearing for quite a long time, but a lot of it has to do with staffing and workforce, which we are also working on with our partners to try to come up with different ways to ameliorate what we're seeing with that. All right, so that is what we did as of April 2023. I will also say, again, MST and FFT have been here in Virginia for a while already. As of February 2023, our estimates say that there are teams in these areas, and the circles is to really show a 45-mile, a really loose estimate of a 45-mile catchment zone area for these teams, but it just lets you see kind of how they are distributed throughout the state, and that not everyone has access to them at all. Not all places even have access to one of these teams, and we're really seeing like a dearth of services in certain areas. And then, but to know that you can go to EBA, Evidence-Based Associates. They have a wonderful map to be able to see that's more up-to-date information month to month on where these services, where FFT and MST are available. You can also go to the respective websites, fftlllc.com, to know where these FFT teams are in Virginia, as well as mstservices.com for the MST teams. And those are pretty up to date. Those are pretty kept up to date often. And then for PCIT.org, we opened a whole can of worms over there with PCIT, more to come about that. But for right now, if you want to find a PCIT therapist, the best way to do that is to go to PCIT.org and look for where certified therapists are providing services through their map. Also, if you have any questions whatsoever, you can always contact us at the center. I've been talking for a very long time. Hope to hear from you. Thank you for your attention. Have a wonderful day.